form radiculopathy, and it's very hard clinically to distinguish between these two. Then the muscles that will be weak will be the iliacus. This is actually a muscle that comes right out from the lumbar plexus, and this, as I said yesterday, flexes the hip. So patients will have weakness with that. The quadriceps, of course, there are a bunch of quadriceps muscles, but they all act together to straighten the leg out. So the knee extension and the adductors will be weak. So notice with either of those, L2, 3, 4, or lumbar flexopathy, all of the muscles that are weak are proximal. Okay, they're above the knee. The area of numbness that the patient will have is the thigh, knee, and L4 extends down to the medial calf. I've actually found that little bit of knowledge helpful many times. If the patient has back pain, numbness in the leg, and you find on exam it goes down to the medial calf, okay, that tells you that clearly the L4 nerve root is involved. And then if we have either a lumbar flexopathy or an L2, 3, 4 radiculopathy, since these are lower motor neurons, remember, then we're going to lose the patellar reflex. Okay, now L5 radiculopathies. Usually what stands out, as I mentioned yesterday with L5 radiculopathies, is the subflavius tibialis anterior. So patients will have, usually that presents with a foot drop. Okay, so back pain, shooting pain down the leg, and the patient has a steppage gait and a foot drop. And you may find weakness then of these other L5 muscles as well. So again, posterior tibialis inverts the foot, peroneus longus everts the foot. Okay, so movement of the foot, either dorsiflexion, eversion, or inversion, are all weak in L5 radiculopathy. And the gluteus medius may also be weak. Again, from yesterday, gluteus medius, patient sitting at the table, and they spread their legs apart. So hip abduction. Okay, the numbness in that case will be the lateral leg, top of the foot. And so a tricky thing here with L5 radiculopathies is that we don't have an L5 reflex, so your reflexes in the lower extremities are normal. Your patellar and your ankle nerve. Yes, it's a lower motor neuron problem. They may have some atrophy over time with these muscles, okay, but they don't have a loss of reflexes. Okay, so again, just think about the case studies that we did yesterday, and we mentioned with the patient that had peripheral neuropathy that several of these muscles were weak. So we will be talking about these muscles in different cases and vignettes throughout the course. Now, finally, S1. So I told you that's the most common radiculopathy. So it's back pain, shooting pain down the back of the leg, numbness down the back of the leg, at the bottom of the foot, and we have weakness of several muscles, but two to know for now are gluteus maximus. Okay, which again, the patient's lying on the bed, you ask them to push their heel down into the bed, you try to lift it up. That's gluteus maximus, and gastrocnemius is plantar flexion, pushing the foot down, stepping on the gas pedal. And then the ankle jerk reflex will be absent. And just something to know for now, patients and even physicians, when that pain, shooting pain down the back of the leg is described, that's often called sciatica. Okay, but sciatic neuropathies are exceedingly rare. So it's never a sciatic nerve problem. No use the term sciatica. It's an S1 radiculopathy. So the only flexopathy that I would like you to know about for now, so it's under lumbosacral flexopathies number 3, is a retroperitoneal hemorrhage. Okay, so when you do anatomy and you're dissecting and you look at the lumbar plexus, this is important. It's formed in the psoas muscle in the retroperitoneum. And so what often happens is when we have patients in the hospital, we're giving them blood thinner, like heparin. And patients may bleed from the blood thinner if the levels get too high, and that bleeding often goes into the retroperitoneum. So they develop a hematoma right around the psoas muscle, right where the lumbar plexus forms. And so patients that have this in the hospital generally complain of severe back pain and numbness into the leg, and so their exam will look just like this. They're going to have weakness of these proximal muscles that we just talked about. They're going to have numbness of the thigh, the knee, down to the medial calf, and they'll have loss of patellar reflex. Okay, so if you see that scenario in a patient in the hospital, they're on a blood thinner, then the first thing you want to do, of course, is we'll stop the blood thinner, okay, and then we can send the patient for a CT of the pelvis, and we can identify the hemorrhage. And as long as it's recognized early, the blood goes away, and typically the strength will improve. Okay, so let me just look. You got a picture here in the handout with the second year medical student doing coming over the summer. Hopefully helps. Alright, so here is L234, and here are the L234 nerve roots coming out right here. Okay, the lesion here is actually out just past the roots, and it's in the plexus. Okay, so I know it's just small on the screen, so maybe you look at it on your handout. But so when you go through anatomy, you'll learn about all these nerves that come off of the lumbar plexus, like the femoral nerve here, the obturator nerve. Well, the femoral nerve supplies your quadriceps muscles and your hip flexors. Okay, the obturator nerve, which you will learn about, supplies the thigh adductors. So these are the individual nerves that supply these muscles that we're talking about. Okay, and then we have sensory nerves here, like the lateral femoral cutaneous. That will give you numbness in the lateral thigh. Okay, and then there are other sensory branches here, which you can see on the screen very well, that will give you numbness of the anterior thigh, the knee, and down to the medial calf area. So the patient will have numbness sort of like this. Okay, this is the left leg here, which is the big toe, so this is the medial calf. Here's the medial calf. Okay, so the weakness here are just the muscles that we talked about in class, and they're going to have a loss of the patellar reflex. Okay, the one other condition, the only other one I'll talk about for now, it's not really a radiculopathy or a flexopathy, but this is such a common condition. We get referrals every single week for this practically, and so it's just a chance to tell you about it, is this nerve here that comes off very approximately, called the lateral femoral cutaneous nerve. Okay, this is a pure sensory nerve that supplies the lateral thigh. That's all it does with sensation. And this nerve actually travels through the groin area into the lateral thigh, and it's very susceptible to compression. Okay, so I had a student here draw a patient, a little bit overweight, wearing tight belts, and that's exactly the type of individual that tends to get compression to that nerve. Okay, so I've seen a number of patients get this just from wearing tight clothing, tight pants. So a tight belt, especially if someone's overweight, you get compression of the nerve, and so patients come in complaining they've got a numb thigh area, lateral thigh area. So you can map this out and find out that yep, lateral thigh, they've got some numbness. But the key thing here is all this nerve does is supply sensation to the lateral thigh. It doesn't innervate any muscles. All right, so reflexes are normal, strength is normal. They just have a passive numbness in the lateral thigh. Okay, so if we have a patient with that, then we tell them about not wearing tight belts or pants, and weight loss, and it may go away if they can avoid compression of the nerve there. I've seen quite a few police officers, firefighters, construction workers that have big tool belts. They may cinch up and they get compression of the lateral cutaneous nerve. All right, so let's talk about the spinal cord here a little bit. And I'd like to start, even though you have these pictures here, drawing it out forces me to go a little slower here and talk about some things. So let's just draw a picture of the spinal cord. And just as an overview, I'm going to put into the spinal cord the different nuclei and pathways that you need to know from this lecture. so first of all, let's talk about sensory, a little bit about sensory pathways that are coming in here. So these are pathways that you know about, but now it's time to get them in more detail. So sensation comes into the spinal cord, and there's a dorsal root ganglion, right there, dorsal root ganglion. All sensation, pain, temperature, vibration, proprioception, the dorsal root ganglion here is part of the sensory nerve root. And the large myelinated fibers that convey vibration and proprioception come into the dorsal horn of the spinal cord. There's no synapse, and they ascend up through these posterior columns. All right, so the posterior columns, we sort of divide this into two areas, the fasciculus gracilis and the fasciculus cuneatus. So when you think of fasciculus gracilis and cuneatus, you want to think of vibration, proprioception, information that's going up to the brain. Okay, and as we'll discuss in the lecture, fasciculus gracilis is everything from T6 and below, and fasciculus cuneatus is everything above T6. Okay, that's in the handout when we get to these pathways. So basically, you want to associate fasciculus gracilis with vibration and proprioception for the leg, and fasciculus cuneatus for vibration and proprioception for the arm. All right. Now, we also have pain and temperature information coming in. And this is very different because there's a synapse in the dorsal horn. And then these fibers cross over and ascend in a pathway here known as the spinothalamic tract. All right, the crossing pathway right here is called the ventral white commissure. So the case yesterday, the patient had Brown Séquard syndrome. One leg was weak, the other leg was numb, and so the key to really understanding that case is to realize that vibration and proprioception does not cross in the spinal cord, whereas pain and temperature sensation does cross in the spinal cord. All right, so those are two sensory pathways. We also have out here in the lateral spinal cord, the cortical spinal tract, or we can call it the lateral cortical spinal tract. And way out lateral in the spinal cord, we have two pathways that are informing the cerebellum about what's going on in the arms and legs. So for the lower extremities, we have the dorsal spinocerebellar tract and the ventral spinocerebellar tract. Okay, there are two for the upper extremities as well, but I'm just going to label here in this diagram the two for the lower extremities. Okay, a couple of other things here just to put in. I'll put it here in this dorsal horn. When pain and temperature sensation comes in, it often ascends for a few levels before this synapse right here. And where those fibers ascend, again, it's in the handout later on, so I'm just going to label it here as LT for sake of space. It's called Lissauer's tract. So this is pain and temperature information. It ascends for a few levels, and then it synapses. Okay, and the synapse right here occurs in the nucleus called the substantia gelatinosa. Okay, and that is one area in the dorsal horn that is worthwhile knowing by name because that is mainly important for pain information. Synapse for pain. Okay, and then out here in the ventral horn, we have a bunch of anterior horn cells. So remember, these are the lower motor neurons. Oops. All right. These are the lower motor neurons that contribute to nerve roots, plexus, peripheral nerves. All right, now the last thing I'm going to put in is there are two things to look for, mainly in the thoracic cord, okay, but it can extend down to L2. So let's put here from T1 to L2. There are two unique structures. One is right here. We have something called the intermediolateral cell column, and these are the preganglionic sympathetics. So go back to our sympathetic lecture. We mentioned that in the spinal cord, those are located from T1 to L2. Okay, so and this is the specific location. Okay, and then the last thing we'll talk about is the nucleus that is only found here and only from T1 to L2, and this is called Clark's nucleus. Okay, and what we will see about Clark's nucleus is that it is kind of a relay nucleus for the dorsal spinocerebellar tract. So actually, it has to do with getting cerebellar information up to the brain. Okay, so I just threw everything out here we're going to talk about here in this lecture, but the diagram will hopefully be helpful to go back to and look at. Okay, so here's a drawing, again, another drawing from a medical student, which is a little more elegant than the one that I just threw out for you, but it has most of the pathways here. Notice one thing I couldn't indicate in the drawing, that the sensory fibers that will contribute to the posterior columns this is supposed to indicate they're large and myelinated. Okay, here the red fibers, you will learn what we mean by C fiber and delta later, but these are small, unmyelinated. Those are the ones that contribute out here to the spinal tract. So a couple of other things that are helpful at the spinal cord. We will, starting next time, probably begin going through spinal cord sections, because if we're going to understand the brainstem, it's really helpful to take these pathways, identify them in the spinal cord, and then continue to follow them as we go up the brainstem. But when we're looking at different spinal cord levels, there are a few things that stand out. This is the cervical cord, and just notice here that the ventral horn, so the neurons here are located in the gray matter, which is this H-shaped structure. So this is a dorsal horn. This is where sensation comes in. This is tangent gelatinosa, as we said, that's important for pain. But the ventral horn here is really large. And when you see a really large ventral horn, you just have to ask, what's in the ventral horn? Well, anterior horn cells. So this means that there must be a lot of muscles that are supplied by this ventral horn. And of course, the cervical spinal cord, think of all the hand muscles and the arm muscles, so it makes sense we'd have a big ventral horn there. Compared to the thoracic cord, look how small the ventral horn is. Okay, and that's because you just have some intercostal muscles, not a lot of muscles here. So you can usually identify about what level of the spinal cord just by understanding a few different clues. So that's one. Small ventral horn, you should be thinking thoracic cord. All right, so first let's talk about the upper motor neuron pathways, and then we'll go through sensory pathways. There is something called a lateral motor system, which really describes two pathways that run together. The one that you know about so far is the corticospinal tract, or more fully the lateral corticospinal tract. But there's another pathway that goes along with it called the rubrospinal tract. So just for review, here's something you should be very comfortable with by now, the corticospinal tract, okay, which crosses in the lower medulla, and now we're emphasizing its course down through the spinal cord as the lateral corticospinal tract. So it's in the lateral portion of the spinal cord. Okay, it communicates with anterior horn cells via a little interneuron, typically. Not always, sometimes it will communicate directly with anterior horn cells. And then, of course, this is the lower motor neuron that will eventually activate individual muscles. And we've also been through and talked about where this travels, and as we go through the brainstem, we'll be able to, in a lot of detail, point to where it is in the brain and in the pons. For now, we're out here in the spinal cord, concerned about its location. The spinal cord right here, And this indicates that if you're moving your right arm and your right leg, the corticospinal tract is activating anterior horn cells at every level that is needed for movement. So if this is a cervical cord that would supply the hand, which you now know is CHT1. Right? That's the level of the spinal cord that supplies the hand. So at that level, the corticospinal tract would activate anterior horn cells, and you move your hands appropriately. And down in the lumbar cord, it would activate anterior horn cells that would move appropriate leg and foot muscles. Okay, now it turns out that the corticospinal tract is much more invested in the cervical cord than it is lower level. So about 55% of the determination is in the cervical cord. So really the corticospinal tract, its predominant function is of the upper extremity. So yes, it does supply the leg as well, but if we had to say what is predominantly involved in, it's with the upper extremity, and especially fine motor control of the hand. So applying tasks like typing, writing, playing the piano, the corticospinal tract would be very involved in that. It turns out the corticospinal tract has what we call a mild flexor bias, which means it supplies a bit more of the flexor muscles than it does the extensor muscles. And notice also the columnar arrangement, which means how the fibers are organized in the corticospinal tract. This drawing is at T1. Okay, and so in purple here is the corticospinal tract. And so just notice that the sacral fibers are lateral, and then the lumbar fibers, and then the thoracic. And if we were to show this at a different level, we'd be able to see that up in the cervical cord that the cervical fibers are most median. Okay. In the second year course, we talk about the clinical aspects of the spinal cord, and there actually is an importance, like if we have a tumor or something, put a disc pushing on the cord, it's helpful to know that the sacral fibers tend to be involved earlier than the more medial thoracic or cervical fibers. So again, we don't see the cervical fibers here because we're just looking at T1. Because we're drawing the cervical cord, then you can see the cervical fibers here. All right, so that's how the fibers are arranged. Now the rubrospinal tract, so several of you asked me, what does the red nucleus do? Well, now we get to come to part of what the red nucleus does. So here's the red nucleus, and the rubrospinal tract originates from the red nucleus. So this is another upper motor neuron pathway. Okay, it turns out that the rubrospinal tract, okay, again, the name kind of tells you what it does. It's going to the spinal cord, and it serves very much the same function as the corticospinal tract. It does pretty much the same thing. So it crosses, it has much more interest in the upper extremity, and also has a flexor bias. So these two pathways travel together out in this area. So it really, when we think of this area of the cord, when associated with the lateral corticospinal tract and also the rubrospinal tract, they travel together. Now, in humans, it looks like the corticospinal tract is much more important than the rubrospinal tract. All right, so here's the drawing here. It indicates that this is talking to anterior horn cells. And so remember that it's more invested in the upper extremity, and actually the lateral portion of the ventral horn here does tend to have more of the anterior horn cells that supply your arm and your hand. All right, now there are several other upper motor neuron pathways that travel in this portion of the spinal cord here. I didn't put it in the drawing here, but we could add it. And these are collectively called the medial motor systems. Okay, so we have lateral motor systems, corticospinal tract, rubrospinal tract, and then we have 4 upper motor neuron pathways that are part of the medial motor system. And just notice that these talk to anterior horn cells really on both sides that have more to do with truncal midline musculature. All right, so these 4 pathways, which when we do our section through the brainstem here, probably in the next week, we will talk about each of these as we get up to the brainstem. But the 4 that travel here are the vestibulospinal tract. Actually, there are 2 of those vestibulospinal tracts. The tectospinal tract, reticulospinal tract, and the anterior corticospinal tract. Okay, so the corticospinal tract that we've been making a big deal of in this course, and that's still the one that's used most often for localized lesions, but just the point is that's not the only upper motor neuron pathway. There are lots of others. So first let's talk about the vestibulospinal tract. Of all of the medial motor, upper motor neuron pathways, this is probably the one that has the greatest clinical relevance, and that is the lateral vestibulospinal tract. This is the most powerful extensor upper motor neuron pathway. Okay, so you want to associate this with extension. And clinically, we use, this is a helpful pathway in patients that are in a coma, which we will sometimes see, patients unresponsive, and their arms and legs are doing this. They're extending, arms extend, the legs extend, okay? And so I will tell you later the localizing value of that, but for now you should know that that powerful extension is overactivation of this pathway, the lateral vestibulospinal tract. It ends up to be kind of a bad prognostic indicator, okay, but that's what results in what we call decerebrate posture. Okay, the medial vestibulospinal tract, so you can tell from the name, this comes from vestibular nuclei in the brainstem. So there's a lateral vestibular nucleus and a medial vestibular nucleus. The medial vestibular nucleus is getting information from the inner ear and is continually relaying that to the cervical spinal cord anterior horn cells so that your neck movement coordinates with what's going on in your inner ear. So when you tilt it off to one side and you make a corrective neck movement because of that, this is the pathway that is involved. So again, it's mainly head turning relative to the vestibular information in your inner ear. So we can give an example of this here. You slip on ice and you're going to extend, right? So that's the lateral vestibulospinal tract. But at the same time, your head may be, tilting off to one direction, so you need to turn your neck as well. So that movement would be the medial vestibulospinal tract. So really, with any movement, we can sort of think about which of the upper motor neuron pathways might be more involved. Okay, the tectospinal tract is something that you're familiar with. The tectum, remember, is the superior inferior colliculus, right here. So the descending pathway from the superior inferior colliculus is the tectospinal tract. And these also travel to the cervical spinal cord. So like the medial vestibulospinal tract, it has to do mainly with neck movement. Okay, so the superior colliculus, contribution to the tectospinal tract, allows you, if you see something off to one side, a visual stimulation, the reason we're so able to accurately turn our head right towards what it is because of the tectospinal tract. Okay, same thing for the inferior colliculus. Okay, that has to do with auditory information, and this is why if you hear something, again, you can just turn your head right to what you heard. So tectospinal tract is turning your head relative to either visual or an auditory stimulus. Okay, so we will see this pathway in the brainstem, but for now you know where it is in the spinal cord is in the medial motor system. Okay, so again, the vestibulospinal tract, tectospinal tract travel here in this area, and notice that these talk to some on the same side, some on the opposite side. So I really don't want you to worry too much about is it crossed, is it uncrossed, because you really cannot localize things very well from lesions here because it tends to talk to the same side and to the opposite side. So the tectospinal tract would talk mainly to neck muscles. The medial vestibulospinal tract would talk to neck muscles. The lateral vestibulospinal tract would talk to extensor muscles. All right, the reticulospinal tract is not as well understood exactly what it does, but the reticulospinal, the reticular formation in the brainstem is just millions of neurons that are packed together in the brainstem, and so they do a lot of different things. But there are two descending upper motor neuron pathways that travel from this area that either originate in the pons or in the medulla. We call these the pontine reticulospinal tract and the medullary reticulospinal tract. And so these have function mainly just to stabilize midline musculature. So they're not as involved with your hand or your foot. Okay, and then finally the anterior corticospinal tract. So remember, out here we have the lateral corticospinal tract. The anterior corticospinal tract refers to about 10 or 15% of the corticospinal tract that does not cross in the pyramidal decussation. So all of those fibers do not cross. Some will continue on the same side. Okay, but it turns out that in the spinal cord, before they synapse and anterior horn cells, they do almost all cross. And so the net result of this pathway is that it essentially is all crossed before it gets to anterior horn cells. The lateral corticospinal tract is entirely crossed from the other side. The anterior corticospinal tract doesn't cross, but before it synapses, it does cross. So that's why it doesn't really matter. When we think of the corticospinal tract, we think of it as an entirely crossed pathway. And from now on, whenever you hear neurologists on rounds talking about the corticospinal tract, they're referring to this one, the lateral corticospinal tract. I don't think we'll talk about anterior corticospinal tract again in this course, but it is another upmotor neuron pathway. Okay, so here is just a complex drawing, and I mainly just want you to appreciate that there are a lot of upper motor neurons that do different things. Okay, so here is the corticospinal tract, right here, going through the motor cortex. There's the corticospinal tract. Along with it is the rubrospinal tract that comes from the red nucleus. Okay, and then we have all of these other pathways that are in the medial motor system. And clinically, it's important. It says mainly extensors. So if we follow this up, we get to the lateral vestibular nucleus. So the lateral vestibulospinal tract, remember, is a powerful extensor pathway. And then we have some, here it says cervical only. So if we follow this up to the tectum, remember the tectospinal tract is neck turning relative to head movement. Okay, so movement is very complex, and it kind of makes sense that we have a very finely tuned brain and brainstem that's able to appropriately move muscles in the precise way that we need to do things. All right, so all of these upper motor neurons then are eventually converging on anterior horn cells, the lower motor neurons. All right, so from the anterior horn cell, we said we have nerve roots. Here's the motor nerve root. Okay, the motor and the sensory nerve root come together here as what is called the spinal nerve, number 3. Okay, and we followed these motor and sensory fibers through the plexus. Well, we just did it for the brachial plexus. So here's the plexus. And then finally, number 5, we have the peripheral nerves. They all packed together here. And then finally, before talking to muscle, of course, there's a neuromuscular junction, number 6. And then we have activation of the individual muscle fibers themselves, number 7. Okay, but again, remember, what is the lower motor neuron? It's 4 things. The anterior horn cell, the nerve roots, the plexus, and the peripheral nerves. Okay, sensory pathways. A couple of these you know already are the spinothalamic tract and the dorsal columns, and sometimes called the dorsal columns medial-lemniscal pathway. Okay, so again, this should look familiar here, but now we want to emphasize a little bit more of what happens in the spinal cord. So for the spinothalamic tract, here's pain and temperature information coming in T3. So this would be in the thoracic area, along the chest. Okay, and as this comes into the spinal cord, it ascends for a few seconds. So this is Lissauer's tract. Okay, and then we have a synapse. So the synapse may be a couple levels higher. And then it crosses over as the ventral white commissure, and then ascends to the lateral spinal cord. And remember, all sensation for the arms and legs goes through EPL of the thalamus up to the postcentral though we're not in the brainstem, just make sure you take note of that. It travels through the lateral medulla, through the steps. So looking at it here, we see the synapse. And so if you just want to circle that, that is the substantia gelatinosa. Mainly. And then it crosses over as the ventral white commissure, and then it travels out here in the spinal thalamic tract. Okay? And just notice here, I know it's hard to see, but the columnar arrangement of the spinal thalamic tract is identical to the corticospinal tract, meaning that the sacral fibers are lateral, and then lumbar, and then thoracic. And if we had a drawing of the cervical cord, we would see the cervical fibers very medial. So this is T1, so these fibers are coming in right here to T1, and then ascending up to the brain. All right, so anatomists have talked about different layers of the spinal cord. These are called rex, lamina, which I'm really not going to talk a lot about, but I will just mention here, because it's important, again, you associate this pathway with the substantia gelatinosa, layer 2. This is mainly important for pain information as it gets to the brain. There's also some synapse in layer 1. Okay, but we want to associate these areas with the pain and temperature fibers. Okay, the dorsal columns, medial lemniscal pathway. Again, this information comes in now, but it's through large myelinated fibers. And so notice there's no crossing in the spinal cord. Okay, so below T6, we call it the fasciculus gracilis. Above T6, we call it the fasciculus cuneatus, but they're really just lumped right together in the posterior columns. Okay, when we look at the brainstem, we will see the synapse up here as the nucleus gracilis and the nucleus cuneatus. So again, in contrast to pain and temperature, where we have the synapse in the spinal cord and then the crossing, for vibration and proprioception, we have the synapse in the lower medulla, and then we have the crossing. So they cross two totally different locations. Okay, the crossing for pain and temperature is the white commissure. Okay, crossing for vibration and proprioception is these are called the internal arcuate fibers. Okay, again, we'll see those in the brainstem section. And then once the pathway crosses over, we call it the medial lemniscus. Okay, it really is just a continuation of the posterior columns, but after the synapse, we give it a new name, and now we call it the medial lemniscus. Okay, so here again we see vibration proprioception coming in, not crossing, but just ascending the posterior columns. Now the columnar arrangement for the posterior columns is exactly the opposite of the corticospinal tract and the spinal thalamic tract. Remember here we saw the sacral fibers lateral, cervical fibers most medial. Okay, in the posterior columns, the sacral fibers are now medial, and then lateral, and then lumbar, and then thoracic. And again, we're kind of drawing through the cervical cord, we see the cervical fibers being very lateral out here. Okay, we also have ascending pathways that are providing information to the cerebellum, and the only two that I will ask you by name are for the lower extremity. Okay, so don't sweat the upper extremity. They're rather hard to identify when we look at spinal cord sections. But you should at least have a big picture that two of these are providing the cerebellum with information from the legs and two for the arms. So the two to know by name for the lower extremities are the dorsal spinocerebellar tract and the ventral spinocerebellar tract. Okay, these pathways for the upper extremity, they're really just providing the exact same information but for the arms, and so we get the different names. Okay, but I've never seen on a board exam where you need to know those. But for some reason, they will ask you about these two. Right, so we've talked about how the dorsal and the ventral spinocerebellar tract are very lateral in the spinal cord. Okay, and the dorsal spinocerebellar tract is kind of interesting. So this is, remember the cerebellum is a comparator. It needs to be always getting information about what your arms and legs are doing. So in the lower extremity, when your leg is moving and your cerebellum needs to get that information, this is how it travels up to the dorsal spinal cerebellar tract. So information is coming in here through the dorsal nerve root, and it actually, for a while, it kind of hijacks with the posterior columns, which you mainly associate with vibration proprioception. But this pathway travels there as well, and it will go up a few segments, and then it synapses in Clark's nucleus. Okay, and after the synapse in Clark's nucleus, then this pathway moves out into the dorsal spinocerebellar tract. Okay, all of the spinocerebellar tracts have a relay nucleus. This is the only one you need to know by name, Clark's nucleus. It has this very unique location right here in the gray matter of the spinal cord. So here it is in the drawing here, Clark's nucleus. Okay, so you just have to associate Clark's nucleus with the dorsal spinocerebellar tract. So it's not drawn here, but again, after the synapse in Clark's nucleus, it moves out to the dorsal spinocerebellar tract and then goes up to the cerebellum. Okay, so 3 out of the 4 spinocerebellar tracts have this basic pattern. Okay, so the information will go in, there will be a synapse, and then, this is not drawn, they're anatomically correct, but it's just to get you a big picture, and then it goes straight up to the cerebellum. No crossing, same side, and if you would just draw a circle right here, okay, we will talk about cerebellar anatomy here next week, but 3 of these 4 pathways go through the inferior cerebellar peak and up to the cerebellum. The ventral spinocerebellar tract, which is the other pathway from the lower extremity, takes a very unusual route to get to the cerebellum. The ventral spinocerebellar tract, in contrast to the dorsal spinocerebellar tract, it's muscle spindles, which we will talk about in the lecture tomorrow morning, that provide this information. For the ventral spinocerebellar tract, it's goal-dependent organs, and that provide the input about how your leg is moving. And notice this one, yes, there's a synapse. It's close to Clark's nucleus, but don't worry about that. But notice this one, it crosses over. It goes to the opposite side, travels all the way up through the brainstem, and then crosses a second time through the superior cerebellar peduncle. So it's a strange pathway because it crosses twice. And probably because of that, it's not infrequently a neuroscience board question. So the ventral spinocerebellar tract is kind of unique. So here's kind of a table, which we'll come back to and we'll spend more time on when we go through the cerebellum. But for now, let's just concentrate on these 2, the dorsal and ventral spinocerebellar tract. So I told you we want to associate these with the legs. So that's why I wrote here below T6. Contribution to the dorsal spinocerebellar tract are muscle spindles, which you will understand after the lecture tomorrow. But the muscle spindles, basically, any little movement of the muscles activates muscle spindles. Okay, so just in real time, we're continuously getting information to the cerebellum for muscle spindles, and for the ventral spinocerebellar tract, it's goal-dependent organs. Okay, the 1A fibers are the fastest sensory fibers that we have, and so it's a little bit faster for the dorsal spinocerebellar tract. Okay, you don't need to know any of the relay nuclei except for this one. So you have to know Clark's nucleus, and that is the relay nucleus for the dorsal spinocerebellar tract. So the dorsal spinocerebellar tract and the 2 for the upper extremity, they all go through the inferior cerebellar peduncle. And so again, the unusual feature here is that the ventral spinocerebellar tract goes all the way up to the superior cerebellar peduncle and then crosses over. So 3 out of the 4 do not cross. So your right arm and your right leg up to the right cerebellum, no crossing. The ventral spinocerebellar tract crosses twice, but it's still headed to the same place. So the net result is the same. Okay, that information in your right leg, for example, that becomes part of the ventrospinal cerebellum tract, will eventually synapse on the right cerebellum. It just crosses twice to get there. Okay? Don't ask me why that's significant, it's just the way it is. Okay, the autonomic nervous system, I'm not going to say much about except that you know where it's located in the spinal cord. Okay, so the intermediolateral cell column, you don't see it that well here, but it's intermediate here in the gray matter. It's between the dorsal horn and the ventral horn, and it's lateral. Okay, so tomorrow I'll show you some pictures of this, but in the T1 to L2 area, these are preganglionic sympathetics. And if we get all the way down to the sacral spinal cord, the parasympathetics, for your bowel and bladder, are located in the same intermediolateral location. Okay, so here we're introducing a whole new subject, so let's stop here and we'll go over some spinal cord circuits and talk more about muscle spindles tomorrow.